We're going to talk primarily about minimally invasive approaches to get to some very difficult problems in the brain and how this might be a good thing for some of your patients. As Andrew mentioned, I'm with Orlando Neurosurgery, and we do most of our work out of Florida Hospital, but we also have privileges at ORMC and do this at both the facilities. And I also have an affiliation with UCF where I do some of my research. So, for the past century, as the field of medicine has developed and the field of neurosurgery has blossomed, there are certain types of tumors that have basically been the albatross to the neurosurgeon. And these essentially are what we call skull-based tumors. They're tumors that involve an area of the brain called the sella turcica, where the pituitary is, areas just above that called the suprasellar cistern, the back of the brain in the posterior fossa, the middle of the brain in the ventricles, and then the other areas along the skull base. And there are several reasons for this. These tumors tend to be very deep. They're midline. They involve the skull base. They often are wrapped around very, very important structures, such as the circle of Willis, the anterior cerebral arteries, the carotid arteries, the optic nerves, the pituitary gland. They often can invade into the hypothalamus and the cavernous sinus. And the bottom line is that there's some very, very important real estate around these tumors, which makes it somewhat problemsome, one, to remove them, but also to get to them. The other problem that we have with some of these tumors, particularly the ones that are in the pituitary area, is that they can affect the function of the pituitary gland itself. And some of these tumors actually secrete hormones where they may have too much cortisol or too much growth hormone, which actually puts the patient at risk from a systemic perspective if you have to operate on them. And then in other patients, the tumors actually cause damage to the pituitary gland, so they don't make any cortisol, which also puts the patient at risk if you have to operate on them. The other problem with these tumors is even if you can get MRIs that look pretty, they have a high recurrence rate. So as much as we'd like to beat our chest and say how great we are in terms of removing these, there is a high recurrence rate with them. And the problem is that if you don't get out all of these tumors, particularly the ones that secrete hormones, patients can actually die as a result of these tumors. Well, over the past actually 10 to 15 years now, there have been dramatic improvements in surgical technologies. And it's allowing us now to be able to actually approach and address some of these tumors that 10 or 15 years ago that we used to call unresectable or inoperable. And it's allowing the morbidities and the complications related to these patients to actually be acceptable. Whereas we don't have to tell the patient, well, there's a 100% chance you're going to lose your hearing, your face is going to be paralyzed, and a 50% chance that your body will be paralyzed. We now are down to single-digit type risks with lots of these procedures, which, if we don't do surgery on, will ultimately result in complications for these patients anyway. So I wanted to start a little bit on and kind of defining what minimally invasive brain surgery is, because it sounds really sexy. Everyone kind of says, wow, this has got to be really neat. It's minimally invasive. And what I want people to understand is that it really means minimal access brain surgery, okay? And what that is that's using small surgical cuts and holes or no cuts at all. It's surgery that utilizes technologies to more precisely navigate to surgical pathology and to treat such pathologies. It often will translate into a smaller incision with less disruption of the surrounding tissues. And essentially, it's an approach to surgery whereby operations are performed using specialized instruments designed to be inserted through small incisions or natural orifices in the body, avoiding the need for large incisions and trauma to the body. Now, it's very important to realize that minimally invasive brain surgery is not minimal risk surgery. They're not equal, okay? It might be minimally invasive in the sense that you're going through a small opening, but that doesn't mean it's minimal risk. It's also, I wouldn't necessarily call it minor surgery, particularly if we're dealing with the brain. And the intent of it is that surgery, the goals of having less pain, less disfigurement, shorter hospitalization, and a quicker recovery. That's the essential purpose for most minimally invasive, at least brain surgery. Tonight I'm going to talk about 6 kinds of surgery that are being done here in Central Florida that I think are a great benefit to our patients. We're going to start with image-guided endoscopic pituitary tumor surgery. We're then going to talk about what is known as the expanded endonasal approach, which is a modification to endoscopic pituitary surgery. Then I'm going to talk a little bit about endoscopic posterior fossa surgery, interventricular surgery, brain port image-guided surgery, and then finally I'm going to talk a little bit about gamma knife, because gamma knife is kind of our ace in the hole if we're unable to remove a tumor and we need some other technology to perhaps get rid of the rest of it. Well, before we can really talk about minimally invasive brain surgery and how it's done, you need to realize that the people that kind of developed the field 15, 20 years ago, they had a tremendous number of hurdles to overcome. 15 to 20 years ago, if you tried to do surgery through the nose or through the mouth and you got through the dura and into the brain and spinal fluid leak, the mortality was over 50%. These people, they had no way of sealing up the leaks, and what would happen is the normal flora in the mouth would migrate into the brain. They would get meningitis or get a brain abscess, and they would die. And so it was considered taboo. You don't operate at the base of the brain through those unclean areas because these people are going to die from infections. And so the biggest thing that they've had to overcome is how do we handle that? And the ways that they've done that is improvements in imaging, monitoring, repairing the defects that are created, instrumentation, navigation, and then also having adjuncts in the event that you can't necessarily get out all of a tumor, that you don't unnecessarily increase the risk of those patients. So I'll start with image-guided endoscopic pituitary tumor surgery. So this is a classic picture that was actually taken by Dr. Spector about 5 years ago. This is a patient with a classic pituitary adenoma, and what we have here was a 4 or 5 millimeter scope, Brian. About 4 millimeter endoscope. It has a high definition lens in it, and what he's doing is we're looking straight back through the nose into an area of the sinuses called the sphenoid sinus, which has now been opened up, and we are looking at, let's see, there we go. We're basically looking at the base of the skull in an area called the sella, and then right here is the tumor. Now, hopefully by the end of the night, some of us will be able to look at this and also realize that right here is the carotid artery, and right here is the optic nerve. And so they're right in proximity to these areas, within a millimeter or two, and in fact often are somewhat adherent to these things. And that is some of the risks that we have when trying to remove these tumors. You have a tumor that's encased in bone that has a carotid artery a millimeter or two away from it and an optic nerve a millimeter or two away from it. When we talk about endoscopic pituitary surgery, we're essentially talking about pituitary tumors. All right? They're one of the most common tumors for people to get in the brain. 10 to 20% of all brain tumors are pituitary tumors. There are several different types, and each one can have a different effect on the body. The problem with pituitary tumors is the anatomy around them. And so here we have an example of a normal pituitary gland with a tumor that is involving it. Just lateral to it is the cavernous sinus, where the cranial nerves for extraocular movements are involved. The carotid artery is running through. Just above it is the optic nerve and the chiasm. Just on top of that is the anterior cerebral artery supplying blood to the front of the brain, allowing us to move our legs. And then just behind this is actually the brainstem and the basilar artery. So getting to this is somewhat problematic. Coming from above, you have the optic nerve in the way. Coming from the side, you have the carotid arteries in the way. Coming from the back, it's the brainstem. And so the only way where there actually is somewhat of an access is coming from the front. This is kind of the typical kind of tumors that we have to do. This is a patient with what's called a pituitary macroadenoma. This patient actually presented with some visual loss. And we can see here on their axial images that this tumor is actually growing up above where the pituitary is, involving the anterior cerebral vasculature. This is the basilar artery right here, just behind it. You can't even see the optic nerve in this patient because it's being displaced by the tumor. But this is a patient who's losing vision that needs to have something done to help save their vision, as well as to help preserve whatever pituitary function they still have. Now, not all pituitary tumors need surgery. For us, there are 3 indications for operating on pituitary tumors. And the reality is that probably 9 out of every 10 pituitary tumors we see, we don't operate on.